So I want to welcome everybody. I know this is a little unconventional to have this, after we've had a meeting 2 weeks ago. And I think some of this is mainly because the information here is very timely. We don't have a huge window to get this information out and potentially act on it if we think we need to or if we think we're able to. And so that's the main reason we're here today. So this is going to be pretty straightforward. Although at the end, if there's any questions or anybody wants to bring up anything for the society, we certainly can discuss it. Just an overview, we'll do this today. We will be looking at having a spring meeting and then also a fall meeting, and both of those will be in person and kind of go from there. So I want to thank everybody for who was able to make it to our winter meeting. We'll discuss in the future whether we actually have a meeting in the winter again, as the winter weather here, as we all know, was unpredictable and it kept our turnout a little bit down. But I do think it was a success to have Dr. White here, and thank everybody who could make it. And I apologize for those who lived more than 20 minutes away from our venue and could not make it. So we're going to start off today. I think that we have two sponsors, and so we thank them for their support. I believe Amgen is up first.
Yes, thank you, Dr.
Nicole is here.
Yeah, thank you so much.
All right, we will move on to our speaker today. And Paul is here. Paul is our the Vice President of Advocacy and Regulation with the NMA. He's our lobbyist in the legislature. This time of year is an extraordinarily busy time of year, so we appreciate him spending some time with us today. He's going to talk to us about bills that have healthcare implications that are in front of our unicameral here this session. So I'll turn it over to Paul.
Hi, everyone. Can you hear me all right? All right, great.
Yes, we can.
Perfect. And sorry, my video is so dark. I'm sitting in front of a big window, but it's still very dark outside. So hopefully if I talk long enough, things will lighten up. But I probably won't fill the full time that Carmen said I have allotted. So if you all have any questions as we go along, feel free to chime in, or there should also be some time at the end if you hear anything that you want more information on or have more questions or any feedback that you want to provide to us. That's always good too. So we're fairly substantially into the 2024 session. It's a short session, so only 60 working days, and will conclude by mid-April. So we're, in fact, over 20% of the way through the session already. I think today is day 17. And bill introduction ended last week. So all the bills have been introduced. We have about 600 new bills that were introduced in 2024, in addition to a substantial number that have carried over from last session. I think nearly 1,500 bills hanging out there. But I'll just go walk through some of the new bills that have been introduced, ones that Carmen thought you all may have some interest in. And then, like I said, happy to answer any questions. So I'll start, I think, with everyone's favorite topic, prior authorization. You all might remember there was a bill introduced last year that was a gold card bill addressing some of the prior auth issues. This year, Senator Wayne has introduced LB 917, also intended to address the prior authorization process. It is not a gold card bill, which didn't really get any traction last year. It would take, what I think is a softer approach. It would require the Department of Insurance to promulgate regulations to address prior authorization and essentially establish a standardized prior authorization process across payers. Those regulations, it sets a few parameters on what those regulations must include, which include allowing providers to submit prior auth requests electronically, requiring that they be valid for a minimum length of time, which the Department of Insurance would determine through their regs. It would require the payers and PBMs to make certain information accessible on their websites, including the prior auth requirements and restrictions, the drugs that require prior authorization, clinical criteria for authorization, standards for submitting and considering requests. And then it would require that the carriers and PBMs provide a process for providers to appeal prior auth determinations. One of the other interesting things it does is require each payer to develop a single prior authorization form for prescription drug benefits to be approved by the director of the Department of Insurance. And it provides that that form should be no more than 2 pages in length. And finally, it sets some time frames. So the regs would require that payers respond within 72 hours for urgent claims and 5 calendar days for non-urgent claims. Moving on to another insurance-related bill, LB 1148 would make some changes to the step therapy law that was passed a couple of years ago. And I know I don't need to explain step therapy to you all, but there was a law passed back in 2021, which the NMA supported, and it provided certain criteria under which health insurers must grant step therapy override exceptions. Currently, that law provides that the law should not be construed to prevent an insurer from requiring a covered person to try a prescription drug with the same generic name and demonstrated bioavailability or a biological product that is interchangeable. This bill would add a statement to that law that it should not be construed to prevent an insurer from requiring a covered person to try a biosimilar. And this is one that I'm still kind of gathering some feedback on. So to the extent that anyone has an interest in that and would like to provide feedback, I would be all ears. For now, I will move on to the next one. LB 1035, 1035, I'm getting this one confused with another prescription drug bill. There are a couple bills out there trying to address kind of access and affordability for prescription drugs. LB 1035 is one that would require DHHS to designate a prescription drug donation program. And the intent here is for Nebraska patients to be able to access drugs through Iowa's prescription SafeNet RX program. As I understand it, Nebraska facilities are currently donating drugs to the Iowa program, but the Iowa program has some discomfort sending drugs back to Nebraska for patient use until it's clear in our law that that's permissible. So that's what this would allow. LB 833 was a bill introduced by Senator Blood, also attempting to address prescription drug affordability. This would establish the Nebraska Prescription Drug Affordability Review Board, which would be tasked with performing affordability reviews of prescription drugs. And that board would have the ability, after reviewing all the information, to establish an upper payment limit for certain drugs that they deem that appropriate for. It's my understanding that Colorado has recently set up a similar board to do this. I know there's some concern that, if this were to be the case, that pharmaceutical companies may make certain drugs unavailable in Nebraska if they think they're going to be taking too much of a loss on them. So I think there's more information to come on that one. I don't know that it's a proposal that has a lot of legs this year, but something to keep an eye on. LB 990 is a bill from Senator Elliott Bostar, which would make some changes to the PBM laws. And Senator Bostar has been interested in this issue for the last few years. This latest bill would provide that PBMs cannot restrict a covered person's ability to choose how a retail pharmacy may dispense or deliver their prescription drugs. It's my understanding there's been a practice among certain PBMs trying to steer patients to their mail order pharmacies if they want to have the drugs delivered to them. So they've been restricting community pharmacies from mailing prescriptions to patients. And this would say that they can't do that if a patient wants to have their prescription mailed from their community retail pharmacy, then they wouldn't be able to do that. LB 896 is a bill that was introduced to kind of streamline a requirement for telehealth consultations. There was something put into our telehealth law that requires a patient to give consent to a telehealth consultation. And if that consent is verbal, which I understand it normally is, that the signed consent has to be collected by the provider within 10 days of the consultation. This was, I think, just an unnecessary paperwork requirement. And to be honest, I'm not sure that there was full compliance with it. So this is a way of streamlining our telehealth regulations for the modern day and age. LB 1087 is the Hospital Association's big push for the 2024 session. It would adopt the Hospital Quality Assurance and Access Assessment Act. It is kind of their way of dealing with the low Medicaid reimbursement rate situation. Essentially, the hospitals would be paying assessments to the state that would be established by NRHS. Based on the type of hospital. And this would allow the state to use that to draw down, those assessments to draw down additional federal funds that would be returned to the hospital through their Medicaid reimbursement. It's projected to bring in about an additional $950 million. So it would be a substantial increase. And I understand there are about 44 other states that do this. It does not change reimbursement from a private practice perspective, but it would be a boost to the hospitals. LB, there are a couple bills, maybe we'll take these together. LB 954 introduced by Senator Kathleen Kauth, and LB 1294 introduced by Senator Bostar, both dealing with biometric data privacy, essentially putting kind of a regulatory scheme in place for any entity that collects biometric data. With one of the bills particularly, that biometric data is kind of loosely defined, and there is some concern among healthcare community that it applies to some of the healthcare data that many facilities, practices would be collecting and storing and making part of their records, and that this would create kind of a whole nother regulatory scheme alongside HIPAA that could be complicated. So we're working with the Hospital Association and others to make sure that to the extent that these bills are seriously pursued, that there's appropriate language in there with the HIPAA exception, research exceptions, and those types of things. LB 823 is a bill introduced by Senator Carol Blood, which would enter Nebraska into the Physician Assistant Compact. Essentially, this would make it so if a PA is from a state that is also a member of the compact, they would have a privilege to practice here in Nebraska without the requirement of obtaining a license, as long as they are licensed in another participating state. This is a very new compact. I think it was just first introduced in other states last year. So far, only 3 other states are part of the compact. 7 other states would have to join in order for it to take effect, or excuse me, 7 states total, I believe. We've reviewed it, or kind of still in the process of reviewing it. At this point, we don't have strong concerns. We don't read it to affect scope of practice or supervision requirements. The law of Nebraska would govern healthcare encounters and patients here in Nebraska. I guess one of the considerations that we always keep in mind is that this somewhat defers to what other states set as requirements for PA licensure and renewal and continuing education, that kind of thing. But like I said, so at this point, we don't have strong concerns about the PA compact. And then maybe the last bill I'll mention, and Carmen wasn't sure if this was something that you all would be interested in at all, but I'm still kind of processing this one as well. So I'm going to throw it out there. This is LV 1187, a bill introduced by Senator Brian Hardin, which would allow registered nurses to perform auricular acupuncture, acupuncture of the ear, at the direction of a physician, nurse practitioner, or physician assistant. The bill is intended, and the language says that the indication for a nurse to do this would be for the treatment of acute or chronic pain, or to manage symptoms of withdrawal during the treatment of substance use disorder. I understand this is currently being done in some of the VA facilities here in this state for treatment of pain. But like I said, still gathering some input on that. So if anyone has heard of this or has any experience with it, has any opinions on registered nurses doing auricular acupuncture, I'd be very interested. So Carmen, that's kind of all the bills I had prepared to go over. If there are any questions, I'm happy to answer.
Paul, with respect to the second to last bill that you talked about with the PA, would that require a PA license in another state to then have a relationship with a PA within Nebraska? And how would that affect their ability to do telehealth?
Yeah, these are very similar questions to what was asked on our legislative committee call on Wednesday night. And I'm still reviewing to make sure the problem with these compacts is they are very dense, very long bills. But what I've gleaned so far, I believe that the requirement for an in-state supervisory relationship would remain. So you would have to have a physician in Nebraska supervising. And I think it's maybe the way the compact interacts with our current state supervising, or our current state laws on physician supervision. I'm still kind of making sure that's all buttoned down. So I can't say that with 100% confidence, but that's kind of where I'm at right now. But let me get the rest of the way through the compact and I'll confirm with Carmen, and maybe she can get back to you all with confirmation on that. And then on the telehealth side, I mean, I think it certainly could have implications for telehealth. I know there are a lot of considerations, in terms of reimbursement. Even the telehealth reimbursement laws we passed last year require that if you're providing telehealth services in Nebraska, then they should be paid the same as in-person services, but only if you're also providing in-person healthcare services here in Nebraska. So there's some complications with that. Maybe they could be using this as a vehicle for telehealth, to provide telehealth from outside of the state, but there may be some complications with how they're reimbursed. And the other thing I would tell you is there's a huge push right now for kind of universal licensure. There's a bill in our legislature right now that we work to try to get physicians out of, but PAs are still in, that basically says, Nebraska will recognize, if you've been licensed in another state, Nebraska will grant you a license in Nebraska for the same scope of practice. So there are all kinds of pushes to make licensure more portable, easier to obtain, and that definitely has implications for telehealth as well.
Paul,
Thank you.
how does that then interact with the insurers? If they have an out-of-state license, but people have Nebraska insurance, then are people paying out of pocket for their services?
I think it depends. I think sometimes out-of-state providers may still be credentialed through your Nebraska insurance plan, and even in network sometimes.
Thanks.
Hey, Paul, this is Alan Erickson. I'm in the conference room. Hi. Question about the first bill that you discussed. So my limited interaction with the insurance commissioner's office has been that it's phenomenally friendly to the pharmaceuticals and phenomenally unfriendly to our patients. So I have great reservations that they have the ability to put together anything that would be anything other than more of that. Has there been any discussion about sort of looking at how the Nebraska Insurance Commission interacts with providers and patients in general?
That is a good question. Because yeah, I mean, I can see your point. I would tell you we have a pretty good relationship with the Department of Insurance, working through some issues with them, but I know that's not always the case on kind of the individual level as you try to navigate complaints and patient issues. So that's definitely something we can put on our radar. I think that's a fair point. And if you have any suggestions for kind of what improving that relationship looks like, I'd definitely be interested to hear them.
Yeah, I would take you up on that offer. So if you would like to try to meet sometime, I can sort of give you what I think my perspective would be from the interactions that I've had with them.
Yeah, that would be great. Maybe Carmen can put us in touch. Yeah, that would be great.
Great, thank you.
Paul, so we've seen a lot of PBM bills kind of explode over the past couple of years, and so where do you? I know you don't have a crystal ball, and we won't hold you to this, but where do you kind of see things heading? What do you think is going to happen with these?
I don't know. I don't know that Nebraska will be on the cutting edge of PBM reform as just kind of a generally speaking, pretty insurance friendly state. So I think, we should probably look at what's happening in other states and see if that's a direction that where things make sense to go. I'm not as well versed in PBM issues as I probably should be. And I wish I had a better answer for you, Dr. Snow, but I'm probably the wrong person to ask about that.
And these laws that apply to like prior authorization, mainly apply to state plans, correct? Or do they apply to all plans that, so for example, if it's an ERISA plan, which is an employer-funded plan,
Mm-hmm.
will these laws apply to all insurance plans in Nebraska or just the ones that are regulated by the state?
Yeah, I think my analysis would be that the law and the regulations that came out of this would probably be preempted by federal law as relates to ERISA plans. It's very difficult to make changes or requirements for ERISA plans. I know the language in case law is always kind of morphing about how states have the ability to it's like, is it a substantive requirement? Is it procedural? Those aren't the exact right words, but I think in general that's kind of interpreted to be fairly strict about what states can do. So we'd be talking about, I think, maybe 50% of the plans here in Nebraska, 50% of the population, I believe.
Do we have any other questions? I guess the one that when you mentioned it, that popped up to me was the hospital. Law where does the NMA sit on this? It sounds to me, and just based on your explanation, that essentially this is setting a regulatory framework that we can get more federal money that would basically help the hospitals. Period. Is that where that's at? And does the NMA feel like that's a good thing?
Yeah, so we have not kind of formalized our position on this. I know we have members who are very supportive. I think, from a lot of physician perspective, it's important to have strong hospitals. And so my instinct is that the NMA will probably take a position of support, but I know our board is still finalizing legislative positions. So I mean, yeah, I think we can certainly see the appeal in drawing down additional federal funding to help out the hospitals, and something needs to be done to improve reimbursement rates across the board. I mean, we like an approach that benefits private practice as well, but that's something that we're pursuing. And I think, in some ways, this may kind of chart a course for other approaches to draw down additional funds for reimbursement across the board. And that's something that we're taking a look at. I know other states are pursuing like payer assessments that would do that. So, like I said, we haven't taken an official position, but most of what I've heard from our members at this point has been supportive.
Great, thank you. Any other questions? All right. Well, Paul, thank you so much for your time. I know it's a busy time for you, and really appreciate you carving a 30 to 45 minutes out for us. I really appreciate it.
All right, take care.
Thanks, Paul. All right, and our second sponsor, it looks like Melanie's on. Orenia. All right, Melanie, are you, the floor is yours. All right, everyone. Well, that concludes this. Expect some information regarding future meetings to come to your email, hopefully in the next couple of weeks, or at least some information. We might be sending a pool out to see appetite for timing of meetings as well. So otherwise, we want to thank you all for being here. We'll give you guys back the rest of your morning, and thanks for making the time for this today. Have a great day.
Thank you.
Have a great day.